Hello, this is Mrs. Castillo, and I'm attempting to record the neuro PowerPoint for Level 3. This is July 24th, and I hope this goes through. This will be coming out of chapters 28 and 32 of your PEDS book. Acute intracranial problems include disease and disorders. They can increase intracranial pressure, which is ICP. The skull has three essential components: the brain tissue, blood, and cerebral spinal fluid, which is CSF. The total volume in the skull should be about 1900 mLs. This is coming from page 928. Acute intracranial problems include diseases and disorders. And we are going to be talking about some of those throughout this lecture. When a person suffers from a neurological insult, normal compensatory mechanisms may fail and the delicate balance is disrupted. The Monroe-Kelly doctrine states that the total contents of the cranial vault must remain at a constant volume in order to maintain equilibrium. If any one of the contents increases in volume without corresponding compensatory decrease in another, the pressure in the cranial vault will increase, resulting in intracranial hypertension. A normal intracranial pressure, or ICP, is considered between 5 and 10 millimeters of mercury. Contributing factors of ICP could be mass lesions, which could include brain abscesses, tumors, hematomas, or hemorrhages. Head injuries like contusions or hemorrhage or post-traumatic brain swelling. Brain surgery. Cerebral infection like meningitis, encephalopathy. Vascular insult like anoxic or ischemic episodes resulting from either a stroke, diabetes, smoking, hypertension, hyperlipidemia, or atherosclerosis. Cerebral infarctions like a thrombotic or embolic. Toxic or metabolic conditions like lead or arsenic intoxication. Note, treatment depends on the etiology. For an example, space-occupying lesions such as a tumor can be treated with a surgical evacuation. In contrast, medical management in the form of osmotic therapy is the cornerstone of treatment for cerebral edema. So again, treatment is dependent on the etiology. Factors that influence ICP are arterial pressure, venous pressure, intra-abdominal or intrathoracic pressure, temperature, pain or agitation, blood gases, like an increase in CO2 levels causes vasodilation. So therefore, when taking care of clients with increased ICP, be sure to monitor all these parameters closely. Now on page 929 in your pediatric book, box 28-1, it's I believe the title is Clinical Manifestations of Increased ICP in Infants and Children. Now, you need to know the difference between the manifestations of infants and in children. They are a little bit different. But generally, there is a change in LOC. There could be complaints of a headache. There could be ocular signs. Vomiting can occur. A change in body temperature, like an increase. Decrease in motor function. Posturing. And the Cushing's triad, which we're going to talk about on the next slide. Now, Cushing's triad is considered when a patient has all three symptoms. For instance, hypertension, an increase in blood pressure, irregular respirations, and bradycardia. You have to have all three of those in order to be considered having the Cushing's triad. Now, when we talk about abnormal posturing, we refer to it as rigid body movements and chronic abnormal positions of the body due to serious spinal cord or brain injuries. Now, there are 4 types, and you really just need to know the two main types that you'll see most often. Decorticate, which is the first one, is a severe dysfunction of the cerebral cortex. So there'll be flexions of the arms, wrist, and fingers with an adduction in the upper extremity. And then extension, internal rotation, and plantar flexion in the lower extremities. Decebriate response is signs of dysfunction at the level of the midbrain. All 4 extremities in rigid extension with hyperprotonation of forearms and plantar flexion of feet. Now the third one you see there that's labeled C, it's asking you what this is. Well, actually this is both of them. Decorticate response is on the right side of the body and decebriate response is on the left side of the body. The next slide is just tells you about increase in cranial pressure and the manifestations of it. And I'm just going to skip over that. I don't need to read that to you. And the next slide is increased ICP and clinical manifestations between infant and child. And again, you can find this on page 929 of your PEDS book, box 28-1. And in infants, you'll see a tense bulging of the fontanelle, lack of pulsations. You'll maybe see irritability and a high-pitched cry, change in feeding habits, and setting sun eyes. In a child, they will complain of a headache. They will have nausea, sometimes vomit. They will complain of blurred vision. They may even have photophobia and may have seizures. So you need to know the difference between infant and child manifestations. The next slide is neurological assessment or diagnostic. How do we diagnose this? Well, we'll obviously do a neurological assessment. We'll need to know the mental status. And on page 929, there is a box there, 28-2. It talks about altered states of consciousness. You'll need to know the difference between full consciousness, confusion, disorientation, lethargy, obtuse, stupor, coma, or a persistent vegetative state. Note, a lack of response to painful stimuli is abnormal and should be reported immediately. Now, there are some diagnostic tests that can be done. These are on page 933 through 934 of your book. They can do a lumbar puncture. They may do an EEG, which is brain waves of this, obviously a brain wave test. Some scans like MRI, CT, or PET scan. Now back to the neurological assessment. They'll start out with the mental status. They will move on to doing the cranial nerve functions, motor function, sensory status, cerebral functioning, and reflexes. Now normally the nurse is not doing all of these. They will do a brief one, like a Glasgow Coma Scale assessment, or they might go into a more extensive neurological exam, but more than likely the physician will be doing a lot of these. Now on to the Glasgow Coma Scale. This is on page 928. Know that it's a quick, practical, and standardized system for assessing the degree of consciousness impairment. It assesses 3 things: eye-opening, verbal, and motor responses. The highest score is 15 for a fully alert person. A Glasgow Coma Scale score of 8 or less is generally indicative of coma. So you need to know what it's for and how we use it. Next page, it talks about management of ICP. And we're first going to talk about emergency treatment. Now you want to look at this on page 942. It talks about head injury and step-by-step process. You will need to know this. The first step, of course, is always airway, breathing, and circulation. And then the next step is stabilized neck and spine. So go ahead and take a peek at that. Now back to the management of ICP. They will use osmotic or loop diuretics to reduce the volume of brain water. And loop diuretics can cause a decrease in CSF production, thus lowering the ICP. Corticosteroids, that will control the cerebral edema as well. High doses of barbiturates, which will decrease in cerebral metabolism, thus decreasing ICP. Osmotic active agents such as mannitol and other different things, but mannitol is the one you'll see the most. You want to monitor fluid and electrolyte status, of course, with all of these drugs. Airway patency is very important. You want to prevent hypoxia and hypercarpenia, so you don't want an elevated CO2. You want to elevate the head of the bed about 30 degrees to enhance respiratory exchange, and it aids in decreasing cerebral edema, but not more than that. It's not really necessary. NG tube to prevent abdominal distension may be necessary. Monitor ABGs. Minimize suctioning and coughing, which could cause transient increase in ICP and a decrease in POS. Monitor for the ICP, obviously. Monitor intake and output. Monitor electrolytes. Avoid rapid changes in body positioning, which may increase ICP. Nursing diagnosis for pediatric clients with threats to neurological function, and usually you want to start out with the airway ones first. So ineffective airway clearance related to unconscious state, altered tissue perfusion, altered nutrition, risks for impaired skin, and risk for infection. Those are usually at the bottom. They are not your primary. Now we're going to move on to some more neurological issues. Seizure disorders, meningitis, hydrocephalus, spina bifida, and cerebral palsy. Seizure disorders. A seizure is an abnormal electrical discharge of the brain neurons. In pediatrics, most idiopathic, some are genetic. Idiopathic means unknown, so they're not known why they have these seizures. Other causes can be CNS infection, head trauma, or neoplasms, or even fever. There are some etiologies and some triggers like stress, anxiety, fatigue, infection, metabolic disturbances. Even certain medications can bring on a seizure. Now, there are different types of seizures. There's partial, which is a local onset, and it usually comes from a small location of the brain. And then a generalized is considered taking place in both hemispheres of the brain. And then there's some unclassified type seizures, like epileptic seizures. You can look at table 28-3 on page 259 for these types. Now, on page, I think it's, maybe I'm mistaken, but I think page 957 to 959, it talks about different types of seizures. Compare simple partial, complex partial, and absent seizures. We will talk about some of these. Generalized seizure is usually the tonic phase is about 10 to 20 seconds. The eyes roll upward. There's loss of consciousness. There's usually stiffness, and it's usually generalized. Symmetric tonic contraction, the entire body does happen. There is some increased salivation, loss of swallowing reflex. Now, the clonic phase usually lasts about 30 seconds, but can last to a half hour or longer. This is violent jerking movements as the trunk and extremities undergo a rhythmic contraction and relaxation. There can be foaming of the mouth, incontinence of urine and feces. Now, posticular phase is a decreased level of consciousness. It's poor coordination, confusion, and very sleepy. You will need to know these different types of phases and what generally happens in these phases. Now, it does say partial has 3 types, simple, partial, and so forth, but you really don't need to break it down too much in the partial. The absent, we call that unclassified now. It's formerly known as petit mal or lapsy, onset between the years of 4 to 12 years in boys and girls, and usually ceases around puberty. This is a brief loss of consciousness. There's no alteration of muscle tone. They're unaware of their surroundings. Absence of seizures are one form of generalized seizure. Typically, this type of seizure lasts between 2 to 30 seconds. The person, most often a child age 5 to 15, abruptly stops whatever he's doing, like talking or walking, and appears to stare into space. An absent seizure rarely causes a true convulsion in which the person falls down or collapses, despite briefly losing consciousness. The person recovers fully with no lingering confusion or other ill effects. These spells may occur infrequently or several times per hour in children. Absent seizures or unclassified seizures may interfere with learning and are often misinterpreted as daydreaming or inattention, if that's such a word. About a quarter of people who have absent seizures or unclassified seizures will develop another type of generalized seizure called a tonic-clonic, formerly called grand mal seizures. The vast majority of children, however, will outgrow them. Page 961, it talks about nurse management of seizures, and the number one emergency, or at least the number one treatment or management of a seizure, is airway and breathing. Okay, so you want to make sure they do have an airway. The next one is safety. Okay, assessing and monitoring the patient throughout the seizure. You usually try not to hold the patient down. You just protect them from hurting themselves. You need to observe, this is very important, that you observe the length. So you got to know the length of the seizure, the activity observed, and then you have to record it. Again, diagnostic tests can be done, CBC, and they're usually looking at the WBC for that. They want to see if there's any infection. CMP for electrolyte imbalance, urine culture, of course, lead and toxicity screening, medical levels, lumbar puncture, MRI, CT, and EEG. Management. Medications can be given, anticonvulsants like Tegretol, Dilantin, Depakote. You want to monitor the drug level of these medications. Diazepam, which is an anti-anxiety, can also be given. Now, we talk about injury prevention, and on page 965, there is seizure precautions, box 28-9. You need to take a peek at that. It talks about what we need to do during a seizure and implementing seizure precautions. So, injury prevention during a seizure activity. You don't want to forcefully restrain the patient. You don't move the patient unless unsafe location. Don't place any solid objects between the teeth. And don't roll the patient onto the side to facilitate. Do roll the patient on one side to facilitate breathing. Okay, so be careful of the do's and the don'ts. Your nursing outcomes, you want to identify those, and usually those are a patient will maintain appropriate rate, rhythm, and depth of respirations during hospital stay. Patient will maintain an unobstructed airway during seizure activity throughout the hospital stay. And patient will sustain no injuries during the hospital stay. And these are your nursing outcomes for patient with seizures. Obviously, the nursing diagnosis are risks for suffocation related to seizures, risk for aspiration related to increased salivation, and loss of swallowing reflex. Your primary ones, though, would be ineffective breathing pattern related to neuromuscular impairment and ineffective airway clearance related to inability to control seizures. Risk for trauma and risk for injury are also nursing diagnosis. Meningitis, the most common infection. Inflammation of the meninges, the membranes covering the brain in the spinal cord. It can be caused by a variety of organisms, bacterial, tuberculosis, viral, or fungal. Page 949, this starts on. Now, bacterial meningitis is on page 950. This is an acute inflammation of the meninges. The cerebral spinal fluid is usually suspected bacterial meningitis is a medical emergency. Okay, this is a medical emergency, and as immediate action must be taken to identify the organism and to initiate prompt treatment. 953, it talks about aseptic non-bacterial meningitis. This is caused by viruses. The clinical course is much shorter. It's typically without any significant complications, and it's self-limiting. Now, clinical manifestations of bacterial meningitis, you will find this on page 951, box 28-4. And it talks about neonates and so forth and what type of clinical manifestations you will see. So in neonates, you may see a hypothermia or fever. There could be jaundice. They definitely will be irritable. They could be drowsy. Seizures could occur. They could be apneic or cyanotic. In infants and young children, they will have a fever. You will see poor feeding. They'll be irritable as well. Maybe some seizures. Some bulging of the fontanelles, nodular rigidity, which may or may not occur. Now, in children and adolescents, there's an abrupt onset, fever, chills, headache, vomiting, alteration in sensorium, and they might have seizures depending. There is some irritability. Photophobia is a main complaint of children and adolescents. So a lot of times when you're taking care of these patients, they will be in obviously their own room. They'll be in isolation, but it'll be dark. They like the lights off and the shades pulled. They may sometimes have a rash. That's not always the occurrence, though. On the next page, there's a slide there. It says under 2, and the one on the right should say over 2 years of age. And this is defining the difference between under 2 years and over 2 years of age. And again, this is on page 951. You will need to know the difference between the signs and symptoms of someone under the age of 2 and someone that's over the age of 2. And this is the clinical manifestations of bacterial meningitis, which is the one that we don't want to see. Diagnostics will do a lumbar puncture, and they will do a gram stain. And what they're looking for to be positive if it's meningitis is increased protein, decreased sugars or glucose, increased WBC, and this usually indicates meningitis. Now take a note of that. That's on page 950. They may have increased WBCs on their CBC count, but they're really looking at the lumbar puncture in the gram stain. That's usually your definitive test. Now, clinical manifestations of viral meningitis can also be headache, fever, photophobia, malaise, meningeal irritation, sore throat, chest pain, generalized achiness, and gradual or abrupt onset. Now, this is on page 954, box 28-5. Diagnostic tests, they will do a lumbar puncture, and this is to rule out meningitis. Now, treat as if bacterial meningitis until ruled out. Okay, until bacterial meningitis is ruled out. Acute bacterial meningitis is considered a medical emergency, so they will start antibiotics right away. They will hydrate the patient, so an IV will be started. Ventilation if need be. They will control seizures if the patient is having a seizure, and they reduce the ICP. And they will treat the ICP as the same as the first slides that you were taught about. Same thing with osmotic, diuretics, and corticosteroids. They will try to reduce the temperature, decrease stimuli, so they'll be in a private room. It will be dark. They won't have very many visitors. They will, if they are an infant, measure head circumference. And of course, they'll be on respiratory isolation. Remember that. They will be on respiratory isolation. They will treat the symptoms, like the fever, with acetaminophen. The corticosteroids, maybe for the ICP. They will give them maybe some anticonvulsants. And they will position the patient for comfort. Now remember, there is an immunization out there now for college students and adolescents. They usually are given this in high school or right before college for meningitis, because it is very common in this age. Please look at page 951 for therapeutic management. And I'm going to stop there and stop this recording and try to record another one.